Welcome to the AI Checkpoints. Before we dive into today's deep dive, just a quick disclaimer. This content is generated by AI. Today, we're really getting into how artificial intelligence is actually changing healthcare. Not just the hype, but, the real-world stuff. We're looking at insights from two really interesting pioneers, Dr. Oliver Aalami at Stanford and Indira Negi from the Bill and Melinda Gates Foundation. Our mission for you, the listener, is to explore how this cutting-edge tech, when it's guided by actual human needs, is transforming health, from new gadgets to global health.
Yeah, and what's really interesting, I think, is how both Dr. Aalami and Indira Negi are so focused on the practical side. It's not just theory. They're showing how AI leads to real improvements for patients, especially where help is needed most. It's about impact.
Okay, let's unpack this, starting with Dr. Oliver Aalami. He's a vascular surgeon at Stanford, but he's also deeply into digital health, kind of bridging those two worlds. His background is pretty unique, too. Born in L.A., grew up in Germany and Iran. Engineer parents, but doctor grandparents. Seems like that set him up for this kind of work.
Absolutely, and it makes you think, right, how do you actually innovate in a way that helps patients? Dr. Aalami, directing Stanford Biodesign's digital health unit, he talks about their main idea. Always start with the need, not the cool gadget first. He basically says, behind every great invention, someone really, really understood the problem they were solving.
So it's not just about dreaming up tech. This whole needs-finding thing sounds key. It means, being a fly on the wall in a clinic, or maybe following someone with a chronic condition day to day, really seeing the struggles.
Sure.
And Dr. Alani stresses looking at it from all sides. The patient, yeah, but also doctors, insurance, billing folks, even the family, the whole picture.
Right. And doing that deep dive into the need, it sort of de-risks the whole thing before you pour money into it. He often mentions the Zio patch as a great example, that wearable heart monitor. It tackled arrhythmias that might not show up in a quick EKG in the hospital. Patients wear it for weeks at home, so it catches those hidden heart issues way better. It really changed diagnostics for that.
And here's where it gets really interesting, I think. Dr. Alami points out that digital health lets this needs finding happen outside the hospital. With connected devices, care can move home. Think remote monitoring for heart failure scales, blood pressure cuffs, sending data back, or like the Omada program for diabetes prevention. It's all remote. It shifts healthcare to where we actually live, making it hopefully, more user-friendly.
Yeah, building right on that idea, moving care out of the clinic. Dr. Aalami's group launched Spezi. It's this open source framework they developed to help speed up mobile health research. He described it starting as kind of a template app, then growing into this modular system.
Okay, Spezi. So it's like a toolkit. What's
Yeah.
inside? And why make it open source? That seems generous, maybe?
Exactly, a toolkit. It has modules for things like connecting to Bluetooth wearables, onboarding users, doing time surveys, that kind of thing. For the back end, they used Google Firebase and Firestore, basically off-the-shelf stuff. The idea was to handle the boring infrastructure parts so researchers could focus on their unique health app features, maybe their special AI algorithm.
Ah, okay. So it lets researchers skip the plumbing and get to the interesting stuff faster.
Precisely. And the open source part. Dr. Aalami apparently really pushed for that, even when Stanford's tech licensing office had questions. He believes there's more value in building a whole ecosystem around it, get more people using it, improving it. Plus, they built in crucial things like thinking about privacy and, importantly, data interoperability. Spezi uses the HL7 FHIR standard. That's the standard the government now requires for electronic health records. So data isn't stuck in one app, it can actually move around.
Makes sense. Data silos are a huge problem in healthcare. Okay, now AI. How does AI fit into Spezi and Dr. Alami's work?
Well, he explained it started out very practically, just needing ways to analyze all the data coming off sensors. This was way before the current LLM hype. You might have health data tracked over months or really high-frequency stuff like raw accelerometer data from a wearable. AI was needed to make sense of it.
Right, just managing the sheer volume.
Exactly. And that leads to a really big opportunity Dr. Aalami highlighted, the 21st Century Cures Act final rule. This is a U.S. government thing, basically saying health record systems have to provide APIs, ways for other software to connect, which means, theoretically, you should be able to get your own health data onto your phone.
Whoa, okay, so putting individuals in control of their data, what could you do with that, especially with AI, like LLMs?
Imagine, talking to your phone using an LLM, asking it to pre-fill those annoying medical forms, or check if your new medication clashes with something else you take, or even just asking, hey, how'd I sleep last week? Pulling data from your health apps. They actually built a demo called Health GPT showing this kind of thing.
That sounds incredibly useful.
Yeah, and another project they mentioned, LLM on FHIR, lets hospitalized patients ask questions about their own complicated medical situation using AI to get understandable answers.
And it's not just text, right?
No, he also talked about image models. Imagine an AI looking at your x-ray and visually highlighting the area of concern, maybe even explaining it simply, making those complex images less mystifying for patients. And he mentioned the sort of low-hanging fruit, too, using AI for translation or simplifying complex medical jargon down to, say, a fifth-grade reading level. Huge potential for bridging communication gaps.
Okay, so that's a fascinating look at digital tools and AI within, more established systems. But what about getting these kinds of advances out globally?
Especially hardware. That brings us to Indira Negi at the Bill and Melinda Gates Foundation. Her focus is maternal and newborn health, often in low-resource settings. Her journey is also really interesting: electrical engineering, Intel, AliveCore, and now the Gates Foundation. She seems like a real hands-on builder type. She apparently mentioned childhood tinkering and her dad building a waterfall. Sounds like that mindset runs deep. Yeah, the waterfall. It definitely sounds like she has that engineering, problem-solving core, plus an early interest in both biology and math. That mix seems perfect for what she does now. She talked about her time at Intel, working on health sensors, but also helping big medical imaging companies like Philips and GE, helping them get AI running efficiently on their existing machines.
Existing machines, how does that work? I thought AI needed super powerful computers.
Well, that's the key insight she shared. Training the AI models, yes, that needs powerful GPUs, which are expensive and use a lot of power. But running the model once it's trained what they call inference, that often doesn't need nearly as much power.
Sure.
Her team helped companies figure out how to run these AI tools directly on the CPUs, already inside things like MRI machines. That makes a massive difference in cost and power needs. Crucial for making advanced tech usable in places without huge budgets or reliable electricity.
Okay, so optimizing for inference, not just training. That makes sense for deployment.
Exactly. And how does this help save lives? At the Gates Foundation, she's investing in devices and software for maternal and newborn health early diagnosis, reducing risks. One really powerful example she discussed involves AI-powered handheld ultrasound.
Handheld ultrasounds, wow. How does the AI work there?
So they're training AI to interpret images from what they call blind sweeps. This means someone with minimal training, like a nurse midwife in a rural clinic, can just sweep the handheld device across the pregnant belly. They don't need to be an expert sonographer finding the perfect angle. The AI analyzes the sweep data and can assess risk factors, estimate gestational age, check the baby's position. Really vital information.
That sounds revolutionary for places without easy access to specialists or big ultrasound machines.
The results they saw were pretty amazing. In Kenya, just introducing these AI ultrasounds boosted antenatal care visits by 20% in 2 years. Apparently, previous education campaigns hadn't achieved that kind of jump in 15 years. Indira noted the women really wanted to see their baby's heartbeat.
That's incredible buy-in. But she also raised concerns about potential misuse, right? Like determining gender where it's illegal.
Yes, that's a critical ethical consideration, especially in places like India. But the tech can be designed to mitigate that. Indira explained the AI can process the images, but only show the health worker, say, a risk score or a color code red, yellow, green. They don't necessarily see the image itself, preventing misuse, but still delivering the essential health information. And importantly, these AI models, even on simple devices, are performing as well as, or sometimes even better than, individual experts with expensive equipment, particularly when the alternative is no screening at all.
That comparison is stark.
It led Indira to make a pretty bold statement. She suggested it's actually becoming unethical not to use AI assistance in medical diagnosis, comparing it to flying a plane without autopilot. The standard of care is just getting higher because of these tools.
That's a powerful thought. Okay, shifting slightly to the latest AI wave, generative AI like ChatGPT. How is that being used in global health? Indira Negi touched on this too, right?
Yes, the Gates Foundation put out a call for generative AI ideas in health and got a lot of interesting proposals. A key theme that emerged was the idea of an AI copilot for frontline health workers in low-resource areas, community health workers, nurse midwives. These workers often follow protocols from doctors, but might feel overwhelmed or, hesitant to ask clarifying questions, which could put patients at risk.
So the copilot is like a chatbot assistant.
Pretty much, like Bard or ChatGPT, but often trained on specific local health protocols and sometimes operating in local languages. An example from Brazil was mentioned, helping workers recall steps for diagnosing childhood illnesses they don't see very often. giving them real-time, actionable guidance.
Sounds promising.
Yeah.
But what are the hurdles? It can't be that simple.
No, definitely not. Indira highlighted two big challenges they're seeing. First, language switching. LLMs often get confused when people switch between languages mid-conversation, which happens all the time in communities using local dialects plus maybe a national language or English for medical terms.
Yeah, I can see how that would trip up current models. What was the second challenge?
Over-reliance and authority. They found some health workers were treating the chatbot almost like a human authority figure, even calling it sir. They trusted it too much. When the researchers deliberately fed the chatbot incorrect information, the workers didn't question it until the errors were really, really obvious.
Ooh, that's worrying. People defaulting to trusting the AI implicitly.
Exactly. It points to a need for a big cultural shift, really. We need to learn to approach AI critically, like we hopefully evaluate info we find online. Indira suggested maybe giving chatbots different personas, not an authority figure, but maybe like an intern, helpful for looking things up, but you need to double check their work.
Like setting expectations from the start. That's clever.
Yeah, or she mentioned an example from South Africa, Quinele, which helps young people dealing with gender-based violence. It uses a friendly and persona supportive, helps to gather evidence, but also allows anonymous questions. It's about designing the interaction thoughtfully.
So designing the AI's persona to encourage critical engagement, not blind faith.
Oh, precisely.
Wow. Okay, reflecting on both Dr. Aalami's and Indira Negi's work, what really stands out is just how vital that mix of expertise is, isn't it? And starting with the problem.
Absolutely. That interdisciplinary approach and the relentless focus on the need first. AI isn't magic. It's a tool. And it's most powerful when wielded by people who deeply understand the real-world problems and the people affected by them.
Yeah, you see it in Dr. Aalami, the surgeon driving digital tools, and Indira Negi, the engineer tackling global health hardware challenges. It really shows what's possible when you blend that deep technical know-how with a genuine focus on making a difference in people's lives.
It really is an exciting time. The potential to expand healthcare access and, make things more equitable globally feels more tangible now.
Definitely a lot to think about there. Hit like and subscribe if you like the content. See you next time.